you, Dr. REVATHI. Could you share your screen?
Yeah. I will stop sharing.
Can you see the slides?
No.
No, I had to stop sharing.
You stop sharing. Dr. REVATHI, just click on the share screen button on the Zoom window.
Can you see now?
No, you will have to click on the share screen button on the Zoom window where the Zoom application is. The green button, 6 o'clock bottom.
Yeah. Yeah, I clicked it.
Then
The pop-up. When the pop-up comes, just click on the share again. On the pop-up, just click on the blue button which says share.
Yeah. Can you?
No.
Are you on Mac, Dr. REVATHI?
No.
Okay.
This is only.
Yeah, it's
Fine.
Yeah, you stopped it, I guess. Just start again.
Start again. Not able to share?
1 second. Can you?
Yes.
Yes.
Perfect.
Okay. Thank you. So thank you for calling me this session, for this session. And Dr. Reddy has very clearly, nicely, he has put that why we have to go for only the cataract surgery. But for me, this information given about this case scenario, they are not adequate. For the first reason, it's mentioned as only 1,000 cells and 600 micron, as Dr. Reddy put it. 600 micron is, it can be even normal, even in a patient who comes for refractive surgery, sometimes we come across. But why 1,000 cells? What is the pathology behind? That's what I would look into. Is it a degenerative or a dystrophic condition like Gateta or pseudoexfoliation, or is it a post-trauma? So what is the reason for that poor endothelial cells? And then also, of course, the patient should have come only for visual symptoms. That's why we are considering cataract surgery. But whether this is not enough. For me, I look at, as Dr. Reddy already beautifully put, the number alone is not enough. In the specular picture, we have to look at the morphology and how much damage has occurred for the cell morphology. And in addition, another clue is whether there is a diurnal variation in vision, whether there is early morning blurring. So you can calculate something like, even some of them can show even 6/6. But if you talk to the patient, they may say that early morning blurring, that shows that that's a warning that this cornea, though it looks clear to you at the time of examination, it's not clear always. And also the lifestyle demand, whether the patient will be ready for 2-step surgery and how their cornea is going to be post-operatively, whether they are ready to accept it and wait for another surgery. So just because it is 60 year, we cannot say, as Namrata put it, many of us in that category, and of course our lifestyle cannot, we cannot, if there is a choice, we will go for a 1-step surgery, definitely. And points to ponder when we are, other points also, that what the patient wants, as I said, a good visual recovery as soon as possible. So what we are going to do by doing cataract surgery alone, if this cornea is, for example, a fuchs cornea. So we may end up with, whatever precaution you take, we may end up with a cornea like this. We may not be so much scared about this, but the patient will not be very happy, but we can reassure them. It may recover in due time, and but at the same time, we have to tell them later they may need another surgery. Or we may end up like this also, even with all due precaution. We may end up like this, and then a cornea like this, and then of course it's a really very embarrassing situation. And in addition, we are talking about the visual symptoms, and how much was of that is contributed by the diseased endothelial Descemet's membrane complex, the negative asphericity by the severe fugues itself can cause some visual disturbances. Of course, that they are not going to be addressed only by the cataract surgery alone. And also we have to discuss about the logistical problem of a patient as well as the attender, whether they will be able to bring the patient again for another surgery. All these things we have to discuss with them, and then allow them to make a decision. And why are we so much concerned about doing a bilateral, I mean, at the same time, a combined surgery? One is we can think about safety, but this is more so in case of open globe PK surgeries. But nowadays, the EK surgeries or closed globe surgeries, it's as easy as just inserting an IOL just behind the iris. You are going to put it just beneath the cornea and put it in position, and just we are going to leave it. It's as simple as that. And coming to the post-op complications, of course, we have to really we have to look into it. One of the main complication I'll be worried about a combined surgery is the CME. CME incidence is definitely high in a phaco with an EK triple compared to either surgery alone. But since we are aware of it, and we'll be looking for it in the immediate post-op period with sophisticated instruments, and we can, even if the like immediately we can find out, and then we can go for preventive measures with very good results also. So the long-term problem about graft rejection, of course, that we have to keep in mind when we are going to replace the endothelium with the donor endothelium. But unlike in PK, the EK endothelial rejection is really very minimal. And if that is going to give the patient a benefit of so many benefits, we have to consider this, and we can manage them as soon as possible. Yes?
Yeah, go ahead.
Yeah.
Yeah, go ahead.
And in conclusion, like one is more appealing logistical reason. And of course, I'll based on all this decision mainly on the basic pathology of the endothelial problem, and also the patient's lifestyle, and what I am going to expect in the immediate post-op period, and also the visual symptom of the patient. And if I can give such a clear cornea in few weeks time post-operatively, I would go for it rather than going for edematous cornea like this. Sometimes it can happen, and I can avoid such an embarrassing situation both for me and a painful situation for the patient. Thank you, and stay safe.
Thank you very much, Dr. J.K. Reddy and Dr. Realty. I'm not going to take the questions because we still have 2 teams to go. I would rather have them opportunity to talk and take the questions to